will be chaired by Satyajit sir and co-chaired by me, Dr. Ajit Poddar, and ma'am Dr. Sharoj Gupta. Evaluation paper ले लीजिए. So, do we have all the speakers? Maurya sir is already here. Vinita Remani ma'am is there. So, Niharika Verma. Okay. Nikhil Sonune. So, okay. Kirti Krishna. Okay. Nirvan Avni Ben. Okay. And Renuka J. So, okay. Sugandha. So, everyone is here probably. Govind Prakash. Govind Prakash is not a Shruti Kochar. Okay. Okay, I welcome all of you. So, let's start. So, Dr. Arvind is already on the dash. So, your topic is all-in-one AI-based smartphone annotating and referral app for 15 common retinal disorders. So, thank you, sir. Start. Thank you.
Thank you so very much, sir. So, good morning, esteemed judges and my dear friends. So, this is a made in India innovation, that is all-in-one artificial intelligence-based smartphone annotating and the referral app for the 15 common retinal disorder, and I have no financial interest. So there is an emerging role of AI in the medical field and ophthalmology. So means there is an accuracy whether looking at the fundus, whether the person is a male or female, and looking at the ECG, the cardiac anomalies, and these can be detected using the AI-based CNN algorithm. And it has a lot of applications in ophthalmology also. So we did the world's first AI smartphone-based multicentric study at 32 centers for annotation and screening app development for 15 common retinal disorders like the mixed retinopathy, retinitis pigmentosa, RP changes, RD, CSR, CNVM, ARMD, the diabetic retinopathy, hypertensive retinopathy, etc. This is how it was done.
This led us to develop our own in-house image annotation tool. As seen in the video, adding in annotations for an image is pretty easy. View the image, magnify it, change the brightness, change the contrast as needed, click on the relevant option, choose the extra details, and the annotation is saved. The analytics on the landing page shows the pending and completed images. The graph shows the maximum number of images stacked by the other users in real time and gave the daily.
So this is the algorithm by which we can detect whether any image that has been captured that requires a referral or not, and it do the quantitative analysis of the different ocular biomarkers within 53 seconds. That is the maximum time. So there is this decision tree based structure. So whether the retina is healthy or unhealthy, and it also tells the DR stage, and if there is extra signs in the laser DR, the glaucoma, or there is the occlusion, DME, or the hypertensive retinopathy, or ARMD also. So it has a binary system whether any patient is require a non-referable or the patient requires a referral. And it is for multiple retinal disorders, also in glaucoma. So this is because all the other the fundus cameras, they are able to detect only up to 3 disorders like the glaucoma, diabetic retinopathy, and ARMD. But this is the world's first which can detect the 15 common ocular disorder, the retinal disorder, as well as glaucoma. And recently we have incorporated the algorithm for the ROP also. So it will be able to detect 16 common ocular problems. So now coming to the results. So as we compared the RID and the APTOS study, there are only 2 other studies in the world. So it was comparable and it was better with this baseline set of 96.17 as compared to the ID-RED. It was 95.45, whereas in APTOS it was 95.74. So it has a very high sensitivity and specificity. Now we have combined with the Ministry of Information and Technology they gave us a grant of 15 CR to make this project Netra Antyodaya, so that all the remotest of the area, they reach this medical retina facility at their doorstep, because any person with little knowledge, even the optometrist, even the nursing officer, they can manage this fundus camera. So it is the lowest cost. It cost is only 1.25 lakh plus GST, and able to detect 16 the common ocular disorder, including ROP and glaucoma, along with other retinal disorders. So this is how it looks, because the other, they are handheld. So the patients are moving, and this is the problem. And in the first phase, it's the slit lamp ophthalmology that along with the camera we have used that can single capture up to 133 degree. And now we have raised it to 150 degree in a single shot. So that is also not there in any the handheld devices. So these are the advantages. So in conclusion, in our efforts in developing the AI-based smartphone tool and Netra Antyodaya non-mydriatic fundus camera for screening and diagnosing, we are ensuring that critical eye care reaches even the most remotest of the area and improving outcomes for the countless individuals. It is easy to use, faster, cost-effective, and a boon for the AI screening and diagnosis in the field of medical retina. And so my acknowledgement, Ministry of IT, NILET, and especially Mr. Rajendra Kotaria, who has given the optics for the this DRDO ISRO, our Chandrayaan project also. Thank you so very much.
Thank you, sir. Wonderful presentation. Dr. Ajit, do you have any question?
No, thank you. It's a very good presentation. It's a very good innovation. 2 or 3 things I would like you to, sir, highlight. Because AI-based screening apps, so there are lots of things has come up in the market. So how it is different from the prevailing AI-based screening image? So
Yes, number one, in the present scenario, the handheld fundus camera, the field is restricted to 125 degree, but we have improved it to 150 degree. Number two, the main factor, the handheld devices, the 10 to 20 degree, 10 to 20% of the images, they are not gradable. So we have this contrast facility, so we can decrease or increase the contrast, right? Also the color coding is there. Also red-free image is also there, and the main thing is blue reflectance. They are using the green reflectance, so that is not good for the optic nerve head analysis. We have blue reflectance, so it gives a very good optic nerve head evaluation. So these are the means. It has many advantages. These are few. Now coming to the sensitivity and specificity, as you rightly said. So we did, nowhere in the world they have developed this algorithm based on 2 lakh images. So at 32 centers, medical retina centers, tertiary centers, we did this study with 2 lakh images, and then came the algorithm. So that's why it is much superior as compared to other things, and that's why we are able to incorporate 16 medical retina disorders and glaucoma and ROP.
Dr. Saroj?
This will basically use for remote areas, so where the specialist.
No, anyone can use it.
No, I am asking, can we have this can be used in areas where specialist is not available, and they
Yeah.
can take the pictures and send to the specialist. So this is a type of handheld fundus camera you are saying, no?
Yes, non-mydriatic.
Yeah, so you have to make this available to all these peripheral centers where the retina surgeon is not available. So is it a smartphone based or a fundus camera based?
Yes, smartphone is attached to it, to the slit lamp. So we
Yes.
need to capture the image, number one. Or we can transfer it to the fundus camera. Or we can directly take the photograph from this fundus camera.
From
Both the
fundus
options are
camera.
there.
If it only smartphone based, then it will be very easy for the remote areas to.
Yes, both the options we have
Yeah.
kept. Smartphone can be, the app is very small. It's 53 MB.
Okay.
So it's not a big size app.
Dr. Rajendra?
Nice idea.
Is it commercially available?
Sorry sir, I'm not able to.
Is it commercially available in the
They are
market?
developing.
Yes, within 6 months it will be commercially available. First, the government it will provide to all the peripheral, the PSC centers, and then it will be available commercially. Yes.
And what will be approximate cost?
I told you, sir,
1.25
1.25 lakh plus
Okay.
GST. So if you compare with Remedio, who is detecting only 3 diseases, ARMD, diabetic retinopathy and glaucoma. And that is costing 4.5 lakh plus GST.
Sir, nice presentation. All these diseases are in the elderly age in which we also see cataract.
Yes.
So the penetration and the accuracy of the diseases that the AI is mapping, does it take the grade of the cataract also into factor?
Yes, very relevant.
Sometimes the
Yes, yes. So we have used the rays, even if the cataract in some part, the rays can enter the retina, we are able to get the picture. But if it is so dense, then it is not possible. But if the rays are penetrate even the dilated pupil, some part, we are able to get the picture.
you said this is non-mediator
And just a
Yeah,
last
no,
question,
we
sir.
need to dilate in such cases.
in such case.
Yes.
Just a last question, sir. Have you gone through all the legal and regulatory compliances while using this
Yes,
AI
yes.
based?
All approval we have already. The Ministry of Information and Technology, they are funding this project.
Okay.
We got 15 CR for this.
Thank
Yeah.
you, sir.
Thank you.
I'd like to thank AIOS for giving me this opportunity.
बहुत noisy है.
I will be talking about heart to eye and ocular complication after cardiac intervention. So the vision loss after the cardiac intervention can be caused by several factors, which could be transient cerebral ischemia, embolic stroke, ischemic optic neuropathy, retinal artery occlusion, cortical blindness, and many other things, with an incidence of 0.06% to 1.3%. The post-operatively, after cardiac surgery, the loss could be because of many factors, could be an advancing age, diabetic, hypertension, or some pre-existing condition, but there are certain factors which are responsible during surgery. It could be because of the hemodilution, because of the anesthetic considerations, or because of the hypotension, stroke, or hypoperfusion. So, we are at the multi-speciality hospital found these complications which are very uncommon, and they require proper investigation that why this happened, so that you will be vigilant enough not to create such type of complications further during the course of the other surgeries. So my aim was to have a case series of retrospective cases which are 6 in number, and it is to create the awareness among the ophthalmologists, because when I saw my first case after a cardiac bypass, the patient lost the vision, I was not giving any answer that why it has happened, because I was not aware of such condition, and when I read and came to know, then I could find out that what was the problem. So these are my 6 cases where I have seen that the causes which are different in each case. So the first case is a 61-year-old gentleman, had a triple vessel disease and underwent an coronary artery bypass, and after 2 days when he developed the consciousness and out of ventilator, he developed a total loss of vision in both the eyes and he could not see. It was only the perception, and he was very disoriented, and it was very difficult to get the examination done for this patient, and everything was unremarkable as far as the ophthalmology is concerned. So I advised the MRI brain, and in the MRI brain there was the areas of ischemias which are there in the parieto-occipital lobe and temporal lobe, and this was because of the embolism which went into the brain because of the carotids which were having these ischemias and the embolic infarcts. So this patient gradually developed 660 vision, but that was not very efficient vision. My second patient, 67-year female, underwent an angioplasty, and I got a call from the cath lab that this lady is not able to see from past 2 hours, and she is like in agony that what has had happened to her. I checked everything, there was no problem with the blood pressure, sugar, the fundus were normal, the pupillary reactions were normal, We just waited and we give the supportive treatment, and 5 to 6 hours she improved. And I could take the fundus, and the fundus picture was absolutely normal. So I just labeled it amaurosis fugax. God knows what happened. My third patient had a transient cortical blindness. It is very unusual complication which can happen after a cardiac surgery. So this is a 57-year male. In the CCU, I have seen this patient, and after CABG, he was not able to see for 2 days, and he was bit disoriented. We were not able to do an MRI without sedation, so we did a CT scan. And for this patient, there was nothing abnormal. As far as the hemodynamics, everything was under control. There was nothing abnormal, but then gradually he recovered. So for this patient, I labeled that it was maybe a transient cortical blindness which was responsible for the loss. Then this is also an interesting male, 64 years, diabetic and hypertensive, underwent angioplasty, and after the plasty, he was recovering well, but then he had 2 episodes of blurring of vision and vertigo, and everybody think that maybe the patient is weak and underwent an angioplasty, so maybe wait for some time. But then he consistently said that he has a diplopia. So because of that diplopia, they called me to the CCU, and I saw that there was a limitation of the movement, and in the right eye, it was more like a third nerve palsy. So when I read it could be an internuclear ophthalmoplegia, or third nerve or sixth nerve isolated can happen following the cardiac intervention. So we underwent we did an MRI for this patient, and it shows little bit of ischemic areas, the infarcts in the right paramedian location, which is the location for the third nerve, or maybe for internuclear ophthalmoplegia. And this patient gradually improved, the diplopia reduced over the 3 months time. My fifth case is 71-year-old male, presented temporary vision loss following an angiography only. He was a chronic smoker, hyperlipidemia and hypertensive patient, and had a triple vessel disease. And on the examination, he was having a 3/60 vision in the left eye, and I could see there is an ischemia. But because he underwent an angiography and advised the bypass, they told that we cannot do the angiography. So this was last case of a partial optic ischemia a lady developed after an angioplasty. So there are so many reports which are available, which are correlating with my findings that cerebral infarct can develop. There can be a developmental of a cortical blindness, or there is a very good systemic review which is being given for the multiple causes which can happen, even to the extent of CRVO, CRAO, and AION can happen following the cardiac interventions, maybe angioplasty, angiography, or cardiac bypass. So there are so many reports which are correlating with my study, but this is the compilation of all my 6 cases, which is it is something new because everyone has noticed one case, but in my study I did so many cases together because I started collecting these cases, and I found that it is rare to find such cases, and probably being a solo ophthalmologist, you may not get the opportunity to see these cases because many of the cases I have seen in CCU, are in ICU, are in the admitted state, not in the OPD state. So this could be an eye-opener because I went through the lot of literature, lot of studies to come to the conclusion that what exactly has happened to this patient. Is it related to the disease itself, or it is related to the procedure itself? And then we have a multi-speciality center which is running very high volume, and we had similar case with the spinal surgery also. So when I went through the literature, they said that these 2 major surgeries, the cardiac bypass and the spinal surgeries, because they have a longer duration, so they have a more complications which are related to eye, maybe an embolic phenomena or maybe in hypoperfusion. So one has to be vigilant, and as an ophthalmologist, it's our duty to see what exactly the causes can be. Thank you so much for the patience.
Wonderful presentation. Wonderful.
Thank you.
I think in the consent form now, before a heart procedure, they'll have to write that you may have a vision loss after the procedure in the consent form.
Yes, when I was going through the studies, there was one of the author has written that probably they have to explain the risk of involvement of the eye, because anyway the CRAO, CRVO can happen, may or may not be related to procedure, but patient may go blind because of the CRAO or cilioretinal artery occlusion, which is very common in such type of patients. But we do reverse. Normally, the cilioretinal artery occlusion or coronary, CRAO comes to us, and then we send it to cardiologist for the further evaluation. But being more of a cardiac center, my hospital is having a high volume cardiac setup as well as the spine surgery setup. So maybe it's reversal now. They are sending patient to me.
Generally in these ICUs, I have seen once they give a referral, somebody just writes on the prescription that patient is having difficulty. It takes 2 to 3 days for the ophthalmologist to actually see, and a lot of vital time is lost. So maybe we can tell them also that whenever any problem happens to inform immediately.
Yeah, maybe I'm available in-house and I'm a full-timer there, so that I can detect. And the similar study I have done for my postpartum patients, which was very eye-opener to me. So in my series of 35 postpartum patients, there are so many causes of vision loss.
Very nice.
It was a very good presentation. Cardiovascular surgery is a known complication for a postoperative visual loss. In one of your case, ma'am, patient was in CCU and he was disoriented. So how could you figure out the hemorrhages fugax?
Initially, we thought of it as ICU psychosis, because many of the patients in ICU, they behave like that. When you see the picture, the patient was totally disoriented and fundus was normal. So we called upon psychiatrist and we called upon neurologist to look into the cause, but then they rule out ICU psychosis. That's why I wrote hemorrhages fugax. But for this particular patient, really I don't know what has happened. But he recovered, so everything is like okay, so we didn't investigate it further.
And second
most of these patients, they don't come for eye purpose, so they are like bit reluctant to go further.
And second thing that, what is your recommendation? Actually, it is usually said that it's after 6 months of the any kind of a cardiovascular surgery, patient should be taken for a ocular surgery or cataract surgery. I'm a cataract surgeon.
Yes.
So that should be that recommendation should be.
So normally we take a fitness. So if you go for angioplasty, if you go for CABG, you have to take a cardiac fitness. And as such also the cardiologist doesn't give fitness before 3 to 6 months because they don't want to stop the medication.
Nice series of cases. What is important here is to how can we prevent this, because so many patients are reporting with the thromboembolic phenomena and nothing to manage in these patients.
So after the compilation of my study, we had a meeting with the OT committee and the cardiologist and the neurosurgeon, and they said that what is the common cause. So the common cause was the hemodynamic changes. And for the spinal surgery, it was the posture which was very important. So sometimes the head was hanging. So now they have taken many of the precautions. The anesthetists now all the time, they monitor the hemodynamics. And I went to the checking of all these patients in the theater and saw that hemodynamically how the patient was stable. So because of the lack of the time, I am not able to give you all details, but it had a very long meeting with anesthetic.
Thank you. Thank you.
Thank you, ma'am. In the meantime, we have a request, so I will request from a chair. So the Dr. Avniben Bhavsar, she had requested for she want to present earlier because she had to leave. So can we allow her?
Yes, please.
So okay, Dr. Avniben Bhavsar, you please come, and your topic is effectivity and safety of subtenant block in manual SICS.
Dr. Vinita's paper should go in IGO also for publishing. Very good.
Indeed, a very good presentation, Vinita. I appreciate it. And this is, I think, every cardiac patients or any patient who is going under spinal anesthesia they should undergo the ophthalmic checkup and this thing should be explained to him. So one should be on the safer side. Very nice presentation. Thank you.
Okay, you can start, please.
Good morning, everyone. I am presenting effectivity and safety of subtenous anesthesia in manual small incision cataract surgery. Anesthetic technique must produce optimal surgical condition, providing good anesthesia for the patient in a safe manner. Peribulbar anesthesia is the most popular technique, but with changing trend in cataract surgery, there is a change in anesthesia technique as well. Several studies have recently investigated the merits of various local anesthetic techniques in use at present. This include retrobulbar, peribulbar, subconjunctival and subtenous anesthesia. The reason for the change in anesthesia technique was because of the use of sharp needle, which was associated with risks such as inadvertent globe perforation, retrobulbar hemorrhage, or direct injection into the optic nerve. Subtenous anesthesia uses a blunt cannula and does not expose patient to this sight-threatening consequences. This is a prospective observational study in patient undergoing elective cataract surgery. Informed consent was obtained from all the patients. Total 140 patient was taken for study. Combination of lignocaine plus bupivacaine with hyaluronidase was used. Pain during injection, surgery, and after surgery was assessed using numerical reporting scale. The exclusion criteria were sensitivity to anesthetic agent, history of convulsion, history of intraocular inflammation, surgery or trauma. The local anesthetic mixture was prepared by using 1500 international unit of hyaluronidase with 30 ml of lignocaine. Now in 5 ml syringe, 2 ml of bupivacaine and 3 ml of this solution is mixed. 0.5% topical proparacaine was instilled and lid speculum was patient. Patient is instructed to look upward and outward. Blunt Westcott scissor was used to make a small nick in the conjunctiva and tenons capsule. The subtenous cannula was then inserted into the bare sclera and guided along the contour of the globe till the hub of the needle touches the sclera. 2 ml of anesthetic mixture was slowly injected into the subtenous space. The results were obtained. Pain during anesthesia was given. Table shows 62% patient reported only mild pain during administration of the anesthesia, while 25% reported no pain at all. Importantly, no patient reported severe or unbearable pain. Table 2 shows pain during the surgery. 52.5% patient reported no pain. 35% reported only mild pain. Again, there is no patient experienced severe or intolerable pain. Table 3 shows akinesia obtained under the different time interval. At 4 minutes post-injection, 85% of patients achieved satisfactory anesthesia, akinesia, while this improved further to 92.5% at 6 minutes. In our study, the subtenous route proved to be comfortable and risk-free procedure compared to the sharp needle technique, which are more often associated, the risks are more often associated with periburbal block. Similar observation regarding the superior safety profile of subtenous anesthesia were made by Lutz et al. The majority of patients experienced only mild pain. In our series, about 52.5% of patients had no pain during the surgery, while the remaining reported only mild discomfort. Joshi et al. Also reported the low mean NRS pain score, less than 1/10 during the block administration and surgery, supporting the high tolerability of the technique. Likewise, Velizadek et al. In the meta-analysis confirmed that the subtenous block provides significant better intraoperative analgesia compared to topical anesthesia. Akinesia was achieved within 4 minutes, and then effect improved with the time as the anesthesia spread through the orbital tissue. This is in an agreement with other author who reported that the subtenous block was comparable to periburbal block, providing adequate good akinesia and anesthesia for surgery. Regarding supplementary injection, very few patients required additional anesthetic with subtenous anesthesia, and the average additional volume was also small. Previous study also reported lower supplementation rate compared to peribulbar block, highlighting the reliability of this technique. The safety profile in overall is good. The most common adverse events were limited to transient chemosis and subconjunctival hemorrhage, which was self-limiting and did not interfere with surgery. No major complication was observed. Similar outcome were described by the Kumar et al., who noted that while anterior subtenous injection may be associated with higher risk of chemosis, this remain far less with sharp needle block. The subtenous anesthesia is reliable and safe, effective technique for the manual small incision cataract surgery, providing adequate analgesia and akinesia with high patient satisfaction with minimal risk complication. Thank you.
Thank you. Very good presentation. So, the first thing, while you were doing the study, the subtenous block and peribulbar block had been given by the same person.
Yes.
So-
And the surgery was also done by the same person.
So, the block has been given by the surgeon himself.
Yes, subtenous.
Peribulbar?
Peribulbar, we have compared only subtenous.
Okay.
There is no comparison between subtenous and peribulbar in our study.
So peribulbar in the untrained hand or a partially trained, usually in our setup we work in a high volume setting. So peribulbar block is given by the optometrist or the
or a
technician.
resident.
And subtenous usually even the fellows or JR, they give the subtenous, or sometimes the surgeon himself. So the only thing is that it's the faulty technique of a peribulbar or it's the right technique of subtenous which gives the result. That's what my point. So it's a proven. Even Arvind has got a study on a very large number of subjects.
Yes.
That subtenous has been proven to be the most effective, safer, and at par result with the peribulbar.
Yes.
So that is my question, that if peribulbar given by experienced hand and subtenous given by the same experienced hand, does it make any difference?
Yes, yes. Peribulbar by unexperienced person is more complicated, and subtenous is with less experience is also complicated.
क्योंकि हम लोग
But
देखते
it is,
peribulbar block जो देता है हम लोग, they usually don't wear anything. Subtenous they wear some kind of a glowing light in their headband, and they use it proper source of the light. Or if surgeon gives, they give it under operating microscope.
Yes.
But peribulbar block usually you give outside and you
Outside,
don't
yeah.
use any kind of things. So that may be the reason which
Yes.
which gauge of needle you are using, which direction of the needle you are doing. So that should be the criteria of
Yes, sir.
before.
So just for information, he's not a high volume surgeon, he's the highest volume surgeon. There's a hospital called Mastichak outside Patna, and they do 150,000 surgeries per annum. Akhand Jyoti Eye Hospital, and they are building the world's largest eye hospital, bigger than Arvind Eye Hospital in Bihar. Dr. Saroj, you have any question?
Yes. So in how many cases you have to repeat? You said repeated and mild volume was injected. So how many cases and how much was injected, the maximum volume?
Only 2 ml was injected.
Repeat. You said we
repeated, in which there is no akinesia or less amount of
So
akinesia.
total
Only
volume
2 ml was
initial was
initial was 3 ml and then
5
extra
ml.
2 ml.
Okay. Thank you.
Thank you.
Dr. Rajendra?
Yeah, this block, subtenous block, because in the bulk, when there is a cam surgery like that, it is not possible to do it, and more skilled person is required. Even peribulbar block can be given by your assistant, like person. So,
Did you have any globe perforation?
No, sir.
But thank you very much.
Thank
Good.
Thank you.
So we call the next.
So the next talk is Dr. Nikhil Sunone. क्या बोले? क्या नाम बताया? कौन सा? ये वाला, the last में, ये ना? So please, Dr. Nikhil, you start. Sir.
Can I start?
Yes, please.
Good morning everyone. I am Dr. Nikhil from Sarojini Devi Eye Hospital and I will be presenting on the topic Eye on the Clock using vitreous humor electrolytes to determine the time of death. As we all know, the number of unnatural deaths is increasing nowadays. So it is becoming more and more important to find the specific time of death. One such substance used to determine the time of death is the vitreous humor. It has electrolytes such as potassium, sodium and chloride, whose concentration estimation can lead us in determining accurately the post-mortem interval. In this case control study, we involved a total of 80 patients of age groups 5 to 83 years. Cases were the patients with unknown time of death brought from outside the hospital, and controls were patients with known time of death who had died inside the hospital. Vitreous humor of both the eyes was collected with the help of a 10 ml syringe and placed in 2 separate bottles. The samples with turbidity, blood stains, and patients with cases with unknown electrolyte profile were discarded. On analysis, it was observed that the vitreous potassium levels had a significant association with the time of death, with potassium levels rising as the postmortem interval increased. It was observed that 1 milliequivalent rise of potassium in the right eye led to a PMI increase of 0.6 hours, and a 1 milliequivalent rise of potassium in the left eye led to a postmortem interval increase of 0.7 hours. Sodium and chloride also did have a drop in their levels, but this was not at all significant.
Nikhil.
This is the graphical and tabular analysis of the right and left electrolytes of the both eyes. So, after comparing with other studies, in a study by Jaffe, it was found that potassium had a positive correlation with the time of death. The results of the study conducted by Balasurya et al., where there was a slight negative correlation between vitreous sodium concentration and PMI, was observed. In a study by Vincent, electrolyte changes are reported to be in proportion with the postmortem interval. In our current study, there was a significant linear relationship between potassium levels and postmortem interval, with no significant correlation between sodium and chloride levels with respect to the time of death. As all studies are there were limitations in this as well. There were very less number of cases involved in our study. Many cases which came from outside did not have a serum electrolyte profile antemortem, and prolonged studies should have been carried out in which a larger population could be screened and in different kind of environments and seasonal variations. So to conclude, there is a relationship between vitreous potassium concentration and time since death, the relationship being linear increase in the potassium concentration after death. At last, I would like to thank the ICMR for helping me with this project. Thank you.
Nice presentation, almost taking you back to forensic medicine classes. How would you actually assess if that person who died had some kidney function disease, kidney disease, and his potassium was raised from before or was low from before?
Exactly.
You're just making an assumption.
Few cases which we had known, they had some brought from outside for post-mortem, and we knew about their electrolyte profile or diseases. We directly excluded their samples. But the other cases we couldn't exclude. That was a limitation for our study.
So what is the clinical implication of this study that you want to know the time of death?
Yeah.
So where it is very important for you to know what is the time of death in patients?
All medical legal
Murder cases.
Medical
like
legal
murders.
and others?
Medical.
Others?
It has multiple uses.
Multiple, that is what I am asking you. There are multiple, besides medical legal, for our ophthalmologists is,
No idea.
okay.
So
we will-
you approached for this study or ICMR approached to you for this study?
No, I approached ICMR. They have that studentship.
So how did you conceive the idea that after getting the vitreous sample for potassium.
Actually,
on,
sir, like,
on a
I-
cadre.
He's asking a Sherlock Holmes question. Why death and timing and all came to your mind? Go ahead.
Thank-
I did this when I was second year undergraduate itself. And like my father is a biochemistry teacher.
Okay.
So like while reading forensic one day, we had read like all the fluids can be assessed to determine the time of death. So like we had a discussion and like we thought it could be a good study to be done.
Brilliant thought. Brilliant.
Okay, thank
In
you.
the meantime, Dr. Kriti Krishna, please be ready for. Please come to the. Request from Dr. Swati Sri. You have a poster presentation. You can delay for some time because.
नहीं जज लोग आगे चले जाएंगे तो फिर कैसे?
A very good morning to you all. So today I'll be talking on the topic exposure keratopathy and conjunctival microbial flora in ventilated ICU patients, a prospective study. So critically ill patients requiring chronic ventilation in the ICU are at increased risk of developing exposure keratopathy, which is characterized by the damage of corneal epithelium due to inadequate eyelid closure. The incidence rate varies from 3.6 to 60% as reported from various studies, and the risk increases in patients with stroke, traumatic brain injury and spinal cord injury. And lag of thalmos in these patients can be due to various reasons like neuromuscular causes, where prolonged use of neuromuscular blocking agents can lead to it, and mechanical irritation while endotracheal intubation can also lead to it. And pharmacological causes like prolonged use of midazolam or fentanyl can also cause relaxation of the orbicularis oculi muscle and lead to incomplete closure of the eyes. And because of these causes, there is also risk of superadded microbial infection, and the most common organisms are Staph aureus, Pseudomonas aeruginosa, E. coli and Candida. So this study was done to assess the eye care in ICU, properly document the presence of exposure keratopathy, its microbiological profile and management of keratopathy. So in a prospective study over 6 months, it included ICU patients on mechanical ventilation and on sedation for more than 7 days, and excluded those with pre-existing ocular surface or adnexal disorders, and the demographics, cause of ICU admission and the nursing eye care protocol were recorded. On days 1, 3 and 7 of the ICU admission, thorough ocular evaluation for lag of thalmos and keratopathy was performed using fluorescein stain and cobalt blue filter, and was graded according to a keratopathy grading scale. And sterile conjunctival swabs were collected on each examination day and was sent for investigations, and ET tube cultures were also sent on day 2, and ethics approval and informed consent were obtained. And our protocol included daily assessment, documentation, lubricants were prescribed every 2 to 4 hours, eyelid taping in case of lag of thalmos, and temporary suture tarsography in case of higher exposure keratopathy grades. And out of the 52 patients in our study, 17 patients, that is 32% patients developed exposure keratopathy, and the incidence was increased in case the ICU stay extended beyond 7 days, that is up to 64% of patients. And based on the grading scale, 9 patients had grade 1, 6 had grade 2 and 2 had grade 3. And the patients with grade 1 and 2 were managed conservatively on topical lubricants, lid taping, and those on higher grades we did temporary suture tarsography as shown in the figure. And out of the 52 patients, on day 3, the most common organisms we found were Staph epidermidis, followed by Propionibacterium acne, Staph aureus, Staphylococcus hemolyticus, and Acinetobacter baumannii. And 22 out of the 52 patients whose stay extended beyond 7 days, the most common organisms were Staph hemolyticus, Acinetobacter, Pseudomonas, and one single culture of Candida was found in a patient with neurological cause. So we found that the Pseudomonas and Candida organisms were present only on day 7, and the ET tube cultures showed Acinetobacter, most common organism, followed by Klebsiella, Aspergillus, and Pseudomonas. And we compared the conjunctival swab and the ET tube culture swab, and in 13.5% of patients it was found to be similar. So antibiotic sensitivity revealed most of the Staph epidermidis, Propionibacterium, and Staph aureus were sensitive to gentamicin, vancomycin, and ciprofloxacin, and some showed intermediate sensitivity to colistin. And so the ICU protocols for preventing exposure keratopathy include mandatory daily assessment topical lubricants, use of shields or goggles, careful patient positioning, humidified air, judicious sedation, and cautious use of anticholinergics. And studies, most of the studies shows higher incidence, but in our study we saw 32%, but it's still significant. And the normal commensals are staph epidermidis, propionibacterium, diphtheroids. Opportunistic infection occurs when corneal protection is lost. And this is one of the first studies to compare ET tube culture with the conjunctival culture, and in 13.5% of patients the same organisms were same in both the cultures. And staph epidermidis was a predominant commensal in ICU patients, while staph aureus, Acinetobacter, and staph hemolyticus were the main non-commensals. And early monitoring and treatment of exposure keratopathy is vital, as neglected cases can lead to severe complications like microbial keratitis and leading to corneal perforation and panophthalmitis. So these are my references. Thank you.
This is a very common problem which we face as ophthalmologists. When you go to ICU to attend a call, most of the patients have legophthalmos and they have exposure keratopathy. So any advisory issued from your side to the ICU nursing staff that they should not happen in future, and but still they don't care of all exposure keratopathy. They are busy with the other managing all the vitals.
It's often
So
neglected.
yes, so have you done anything to prevent this in your setup?
We advised all the ICU.
How much it is followed, that is important. We also advise them every time, but every time you go, patient will have exposure keratopathy.
What we could do was we went on reviewing the patients daily. We went and advised them to follow, and we made sure that the sisters were doing it. Like we made them do it in front of us. Like every day we were reviewing the patients.
It's not possible for us to review every day. They have to follow the protocol. The nursing is attending these semi-conscious patients.
There are many studies like this which have been done earlier in the hospitals. How was your study different from the other studies that have been done earlier? For many, many years, these studies have been going on.
Yes, sir. Sir, we compared with the endotracheal tube cultures also as well, sir. So we found if it was similar, what we do was we could like same organisms were seen. So prophylactic targeted antibiotic therapy can be started earlier so that we can prevent the microbial keratitis. That was something.
So these studies were almost matching to what has been done earlier.
This comparison we didn't see, sir.
You have not done,
in
because there are
our
many
research.
studies like this which have been done earlier.
Okay.
Thank you very much.
Thank you, sir.
So the next speaker is Dr. Sugandha ji. Doctor. And after Dr. Sugandha, Dr. Govind Prakash will be ready with their presentation.
Good afternoon, everyone. Today I'll be presenting on the topic impact of intravitreal ranibizumab on visual acuity, contrast sensitivity and stereopsis in patients with diabetic macular edema. As we all know, diabetic macular edema is the leading cause of visual loss in diabetic retinopathy, and vascular endothelial growth factors plays a central role in the pathogenesis of diabetic macular edema. And also however, the real world functional vision depends not only on visual acuity, but also on contrast sensitivity, which is required for things like night driving, and stereopsis, which helps in climbing stairs. But there's a gap in literature, since landmark trials like RISE, RIDE and RESTORE primarily focused on visual acuity and OCT, with little emphasis on contrast sensitivity and stereopsis. Coming to the objectives, our primary objective was to assess the visual acuity, contrast sensitivity and stereopsis changes in patients with diabetic macular edema before and after intravitreal ranibizumab injection, and the secondary objective being to correlate the visual function improvements with central retinal thickness as seen on optical coherence tomography. Coming to the materials and methods, a prospective cohort study was conducted on patients diagnosed with diabetic macular edema undergoing ranibizumab injection. All patients underwent the following series of evaluation. Firstly, the best corrected visual acuity was checked using the Snellen's chart, followed by contrast sensitivity using the Pelly-Robson chart, followed by stereopsis using the Randott stereo test, followed by the dilated fundus examination using slit lamp biomicroscope plus 90D lens, direct and indirect ophthalmoscope, followed by the central macular thickness was measured using the optical coherence tomography, after which the patient was subjected to intravitreal ranibizumab injection 0.05 mg per 0.5 ml. The study patients included patients coming to the ophthalmology department who are diagnosed with diabetic macular edema satisfying the inclusion and exclusion criteria. The study duration included 6 months from March 2025 to August 2025. Study design was prospective cohort study and the sample size included 30 patients diagnosed with diabetic macular edema. The visual acuity, contrast sensitivity and stereopsis was evaluated preoperatively on day 1 after the injection and 1 month following the procedure. The inclusion criteria included the diagnosed cases of diabetic macular edema with central macular thickness more than 275 micrometer and decreased vision due to foveal thickening from DME with no other cause, patients receiving intravitreal ranibizumab for the first time, and the best corrected visual acuity ranging from 612 to 660. The exclusion criteria included patients with significant media opacities, patients with previous treatment with alternate anti-VEGF therapy, presence of any coexisting macular disease, and also the history of medical use of substances with known impact on contrast sensitivity. Coming to the results, the best corrected visual acuity was tested at baseline, POD1 and 1 month. At baseline it was 0.53, which was calculated in log and in logMAR. In POD1 it gradually improved to 0.36 and in 1 month it further improved to 0.24 and the improvements in both POD1 and 1 month was statistically significant. The contrast sensitivity is also measured at baseline, which was found to be 0.42 and on post-op day 1 it was 0.66 and 1 month it was 1.16, which showed a gradual improvement over 1 month. And the improvements in both POD1 and 1 month was also found to be statistically significant. The stereopsis at baseline was 2.09 and POD1 was almost the same, being 2.05, but 1 month it was found to be 1.71 and the p-value for POD1 was not much statistically significant, but after 1 month it was found to be statistically significant. The central macular thickness was also measured. At baseline it was found to be 361 and on post-op day 1 it was almost the same, 361, and 1 month it was 261 and it was statistically significant after 1 month. I would like to showcase like how our study is different from other studies. There were other similar studies conducted on this topic, which included Okamoto et al. Where they found their primary focus was the relationship between stereopsis and the quality of life. And in one more study conducted in 2022, they mainly focused on the effect of ranibizumab and PRP on contrast sensitivity in PDR. And in the RISE and RIDE trials, which included long-term efficacy and safety data for the regulatory approval. But our study mainly focused on combining contrast sensitivity and stereopsis in diabetic macular edema with OCT correlation. Coming to the novelty of this study, it goes beyond visual acuity. Most of the major trials like RISE, RIDE, RESTORE study focus primarily on the best corrected visual acuity and OCT thickness as endpoints. And but our study focused on functional as well as anatomical outcomes. And also the contrast sensitivity reflects quality of vision in low contrast environments like night driving, reading faint print, etc. And stereopsis assesses binocular depth perception, often neglected but important for fine motor tasks like pouring and threading a needle. It also adds evidence that anti-VEGF treatment not only reduces macular thickness and improves the visual acuity, but also restores the quality of vision parameters that matter most to the patients. Coming to the limitations of my study, it included a small sample size, there was a short follow-up period, and it was a single injection protocol. These are my references. Thank you.
Thank you, it's very good. So you had used a ranibizumab biosimilar or
Biosimilar.
okay. So in methodology you should have specifically mentioned that you have used the biosimilar and which thing, because the product specificity is important. Second, why this study has been done on a biosimilar, any specific region on the ranibizumab? You didn't do it in a bevacizumab or other anti-VEGF.
We wanted to include ranibizumab because it's like most commonly available in the market.
Did you have a financial disclosure slide in the beginning?
No, sir.
You have to add that.
Your follow-up is only 1 month.
Yes,
These
it was a
patient-
short follow-up.
Yeah, these patients need a repeated follow-up after 3 months. So what happened to their contrast and the color vision on the long-term follow-up? That has to be included in the study. It's a very short duration study. Follow-up is very short.
We included pseudophakic cases as well in your study.
Sir?
Post-operative cases, post-cataract surgery patients.
Post.
You included in this
Yes,
study.
sir. Pseudophakic and phakic also were in.
But their contrast sensitivity is already compromised after putting the IOL. That should be excluded from your
Yes.
study.
There should be clear demarcation.
So what was your final conclusion? Contrast sensitivity and the stereopsis correlated with the CMT and the
And stereopsis.
thickness of CMT and the BCVA.
Yes, sir. BCVA
So it has-
correlated with the reduction in the central macular thickness.
So what was the new in that? Because
Even the contrast
if it's-
sensitivity also
if it-
showed a correlation with
it
decrease
is
in
supposed to
central
be aligned with the gradually as the CMT will decrease and BCVA will improve. So contrast sensitivity and stereopsis will also improve.
Yes, sir. But other studies haven't compared visual acuity, contrast sensitivity, and stereopsis. We had included all the 3 parameters in our study.
So now
Thank
his question is, anyway, it will improve. What different are you trying to say? Because if you give this injection, the contrast will improve, the vision will improve, the stereopsis will improve.
But there were no other studies comparing all the 3 parameters of functional visual recovery, which we have included in our studies.
Okay. Thank you very much.
Thank you. So the next speaker is Niharika Verma, Dr. Niharika Verma.
Good morning, everyone. I would like to thank IOS for giving me this opportunity. I'll be presenting on the topic ocular toxicity of anti-tubercular therapy, a prospective study using OCT. Now, why this is important? Because as we all know, that tuberculosis is a global challenge with millions affected annually. In India, 27% of India accounts for 27% of the global load. The present ATT regime, though is highly effective, has series of adverse effects like hepatotoxicity, nephrotoxicity, neurotoxicity, and ocular toxicity. One of which is ethambutol-induced optic neuropathy, which manifests with decreased visual acuity, color vision defects, and visual field abnormalities. So it is important to detect this early, and OCT is one investigation which can be used for this. The aim of the study was to evaluate the ocular toxicity of anti-tubercular therapy using OCT as an early diagnostic tool for structural changes in the retinal nerve fiber layer. The objective was to assess the baseline visual acuity, contrast sensitivity and color vision, and RNFL thickness in patient before initiation of anti-tubercular therapy and at 1 month and 3 month post-treatment initiation of treatment. The secondary objective was to correlate these OCT-derived structural changes with clinical symptoms and visual function parameters. It was a prospective observational study for a duration of 6 months in a tertiary care hospital where a total of 40 patients, 80 eyes were included who were initiated on ATT, which included ethambutol. The inclusion criteria was age above 18 years, best corrected visual acuity of 6/18 or better, patients who were newly initiated on ATT and who were willing to undergo ophthalmic evaluation. The exclusion criteria were any condition which could infect the RNFL, that is any pre-existing ocular condition, alcohol or smoking, systemic condition affecting vision, other ocular medications causing ocular toxicity, or patients who were non-compliant. All participants underwent a comprehensive ophthalmic evaluation at baseline, 1 month and 3 months. The investigations include best corrected visual acuity, color vision testing, contrast sensitivity, slit lamp biomicroscopy, dilated fundus examination, intraocular pressure, and RNFL analysis. SPSS software were used for statistical analysis. Now the results. This is the age distribution graph with the mean age of the participants was 42.6 plus minus 10.3 years, 24 were males and 16 were females. Now coming to symptoms, we saw at 1 month only one eye showed defect in color vision, while no one had decrease in visual acuity or contrast sensitivity. While at 3-month follow-up, one had decrease in visual acuity and contrast sensitivity and 2 eyes showed defect in color vision. Now coming to RNFL analysis, at 1 month follow-up, there was mild thinning of the RNFL which was observed in 9 eyes. It decreased, average decreased from 102.4 to 98.6, which it was not statistically significant, but at 3-month follow-up, when it reduced to 94.3, it was statistically significant and it was seen in 15 eyes. Now coming to conclusion, this study highlights the potential ocular toxicity associated with antitubercular therapy with early structural changes detectable through OCT even before the onset of significant visual symptoms. These findings emphasize the importance of regular ophthalmic monitoring, including OCT evaluation in patient taking ATT. The further direction could be we could do a multicentric study, extended follow-up needs to be done, reversibility of these changes could be studied, and a standardized monitoring protocol should be made. Thank you.
Nice presentation, Dr. Niharika. Did you come to some kind of a conclusion that all these patients who get ATT, all the patients who are getting anti-tuberculous treatment, some of them, their optic nerve will have more toxicity, some will have less, like in RNFL changes.
Yes.
So what conclusion did you come to of which segment of patients are getting more affected or less affected? Because getting affected, we know for many years that ATT medicines affects the optic nerve. But were you able to reach some conclusion?
The patient with comorbidities had higher risk, like because ethambutol is excreted by kidneys. So patients who had kidney diseases were affected more than other patients.
You have included and mentioned that in your study?
Sir, it is an ongoing study. This is a part of that study, so I'll be publishing it.
What do you think is the reason that those who have kidney disease have more optic atrophy
Sir,
changes?
because ethambutol is excreted by kidneys, so there is decreased excretion of kidneys in patients who have kidney diseases, so ethambutol toxicity is more in them.
Thank you.
Thank you, thank you. Can I call Dr. Classroom instrumentation? In Prakash, please.
Good morning, everyone. It is actually the keynote address. The topic is impact of flipped classroom implementation in ophthalmology undergraduate courses.
Is this a...
Okay. So the medical education is undergoing a shift towards innovative learning approaches. Growth in information and technology demand active learning and skill development. Ophthalmology education faces challenges due to limited time in the curriculum. The flipped classroom model offers a solution by replacing lectures with self-paced videos. So research supports the effectiveness of flipped classrooms in various...
Swati, 1 minute. Is this for marking or...
No, it's not for marking.
Not for marking, right? You got an award also for this.
Yes, sir. Yes, it is a keynote address.
Sorry. Congratulations. Very
Thank
good.
you, sir. So limited research exists on flipped classroom specifically for ophthalmology. So what is flipped classroom? It's a pedagogical approach that inverts the traditional teaching methods. Students engage with course material independently before the class, like videos and readings, and the class time is dedicated to active learning activities like discussions and problem solving and projects. So the benefits for students is it is self-paced, it has increased engagement and motivation, it has enhanced problem solving and critical thinking skills, and for teachers, there is more time for individual attention, and gives opportunities to foster deeper learning. It has enhanced student-teacher relationships. So a meta-analysis had demonstrated the superiority of the flipped classroom over traditional lectures, and Tang et al. And Lin et al. Studies that demonstrated the successful implementation in teaching ocular trauma and glaucoma. However, preparing recorded lectures and securing faculty support requires significant time investment. So while the flipped classroom offers benefits, its effectiveness across the entire ophthalmology curriculum remains unexplored. So the objective was to assess the impact of implementing a flipped classroom approach in ophthalmology courses for undergraduate students. So 6-semester undergraduate medical students, and the intervention was flipped classroom method. So that was compared with didactic lectures, and the outcome measures were evaluated with pre and post-exam test scores, the post-intervention skill exams, and qualitative feedback. So in flipped classroom, before the class, they were asked to watch online videos, share study materials and supplementary content, 2 days of self-studies time. Then in the class, there was a pre-class test, and then there was a question answer session and interactive group discussions. After the class was summarized, the study material was reviewed, and post-class test was done. So these are some examples of what could be shared. Then the didactic lectures, it was just a pre-class test, and you listen to the didactic lectures, and that is followed by a question and answer session, post-class test, and skill assessment. So in statistical analysis, the qualitative data that was represented in counts and percentages, quantitative and mean plus standard deviation. So the pre and post-class test scores that was statistically compared by using pair t-test at significant level of 0.05. A Likert scale was used to grade the responses, and SPSS 20 was used. So when the mean pre-test and post-test scores were compared in various age groups, and in flipped classroom, it had a better performance. So in flipped classroom, it helped them in understanding the subject and content retention to create interest, and the level of interaction was also quite high. The ability to hold concentration was better, but it required a high amount of preparation. So the practical learning was better in that. So it exhibited significant improvements in self-rated learning ability compared to the comparison group, and the intervention group skill exam scores were statistically significantly higher than those of the comparison group. The qualitative feedback also supported the positive impact of this approach, and there was no statistically significant difference between during practical skill demonstration. So it was a highly effective model in enhancing student learning outcomes in Ophthalmology. So students achieved comparable or superior performance in a significantly shorter time, and it received positive feedback from the students. They valued the flexibility and active learning opportunities, and it had the learning strategies like group discussions and problem-based learning. They were integrated into this model. So the use of technology, it can enhance the student engagement. The students can learn at their own pace and revisit the material as needed. It can be adapted to different learning objectives, and future research can further explore the long-term impact of this. So further, the studies can also investigate the cost effectiveness of this approach. So it is essential to assess the technical requirements and infrastructure. Faculty development programs can be implemented to equip educators with these skills, and evaluating student satisfaction and feedback is crucial. It has the potential to revolutionize medical education and prepare future healthcare professionals for the challenges. So coming to the limitation, it requires significant technology and computer access, which may limit its applicability in resource-poor settings. Student fatigue and focus on new subjects can further reduce the survey response rates. So to conclude, for implementation, it requires careful planning and organization, high-quality instructional materials, effective classroom activities and assessments, technical support and training for faculty and students, ongoing evaluation and refinement. So by addressing these challenges and leveraging the opportunities, the flipped classroom can be a valuable tool for enhancing ophthalmology education. These are my references. Thank you.
Thank you. This was the keynote address, so there's no question and answer as such, and we are falling short of time. Unless Dr. Ajit or Dr. Saroj, you want to say something? Otherwise, we'll move on to the next topic. You can call the next
So,
speaker.
Thank you so
please.
much.
thank you. I would like to answer one. I would like to clear myself. Will you please describe how should it look like a flipped classroom and how do you conceive the idea? Because I believe even in the younger nursery stage and the school classes, there are a lot of innovation in the classroom lectures.
Yes,
So,
sir. So this is basically like in the didactic lectures, you are directly coming and putting your slides and trying to teach the students. But in flipped classroom, it is like before the class, when you have a scheduled class, 2 days before the class, you try to provide them with instructional material, your notes or your videos, and give them the study content. The students are rather than them coming as a zero knowledge, they come with some knowledge, and then they sit for the class. And then you can like that time of 45 minutes or 1 hour that you have for the class, you do not completely engage in just putting your PPTs. You can engage them more in discussions and group discussions, and it can be more interactive
Good
actually.
idea. Good idea. Dr. Renuka J.
so Dr. Renuka ji, नहीं है ना. Dr. Renuka J.
Dr. Govind Prakash is present. So we mark him absent, no?
Good morning, everyone. The title of my paper is A Modified Approach for Haptic Stabilization in Sutureless Scleral Fixated IOLs. No financial interest or conflicts to disclose. Inadequate capsular support pose a unique surgical challenge. Capsular deficiency can either be due to a complicated cataract surgery, trauma, or any syndromic association. SFILs are superior in these cases as placing the IOL close to its natural lens position avoids complications and provides a better visual advantage. Furthermore, sutureless fixation avoids knot erosion, breakage, and IOL dislocation. The aim here will be to describe the novel approach for exteriorization of the haptics. It's not moving, sir. In sutureless, to describe a novel approach for exteriorization of the haptics in sutureless SFIL and to assess its efficacy, and it is a prospective interventional case.
ऑडियो विजुअल जरा देखिए क्या स्क्रीन पे आ रहा है ऑडियो विजुअल स्क्रीन पे क्या आ रहा है
And it will be a prospective interventional case series. 4 cases had been included in our study. An anterior approach of sutureless scleral fixation was done in all the cases using a multi-piece IOL.
Will you pause for a second because it's not visible. We cannot see your slides.
Can you start again, please? And please wait 1 minute. When we tell you to start, then start. There's something coming on the screen here. We can't see.
Title of my paper is A Modified Approach for Haptic Stabilization in Sutureless SFILs. No financial interest or conflicts to disclose. Inadequate capsular support pose a unique surgical challenge. Capsular deficiency can be due to a complicated cataract surgery, trauma, or any syndromic association. SFILs are proven to be superior as placing the IOL close to its natural lens location provides a better visual advantage as well as less complications. Sutureless approach avoids knot erosion, breakage, and IOL dislocation. The aim here will be to describe a novel approach for exteriorization of the haptics in SFILs and to assess its efficacy. It is a prospective interventional case series. The methodology included 4 cases who had presented with aphakia. An anterior approach of SFIL fixation using a multi-piece IOL was used. The optic insertion was done as described by Emanis technique, but flanging was not done in any of the cases. Exteriorization and stabilization of the haptic of the IOL was done with the help of an iris hook plug. This is the image of how an iris hook plug is used using a 26 gauge bend needle, where you can see the like silicone iris hook plug being introduced into the 26 gauge needle. And post-operatively, visual acuity and IOP were recorded, and centration and degree of the tilt were measured with the help of an anterior imaging. This is the anterior imaging where you can see the IOL tilt and centration could be measured post-operatively 1 month. Coming to the case details, this included 4 case series. First case was of a 7-year-old female post-cataract surgery who was left aphakic. SFIL was planned in this case. And this is the entropic, where in the first image you can see the IOL aptic being exteriorized through the bore of the 26 gauge needle, and the procedure is repeated on the other side. And postoperatively, this patient had early postoperative IOP elevation, which was managed medically, and this is the 28-day post-op image where you can see the IOL being centered and in proper position. And second case was of a female who had no history of trauma, just had a history of cataract surgery. The posterior segment evaluation showed a dislocated IOL in the anterior vitreous face, and SFIL was planned in this case after explanting the IOL, and it was a 3-piece IOL, and the same IOL was implanted back by the same technique described above. And in this technique also, the IOL was well centered and the visual acuity improved to 624. The second case was of a trauma patient who had corneal tear repair. Post corneal tear repair, he had to go for vitrectomy, and then SFIL was planned in this case. And this is the post-op pictures where you can see the IOL being in center. And fourth was of a case of a young pale post-trauma who had scleral tear repair, and similar technique SFIL was performed in the same patient. And this is the anterior segment image where you can see the scleral tear being sutured. And this is the image where you can see the toric marker being used for marking the tunnels in case of a SFIL, and this is also an important step so that your haptics are in 180-degree apart exactly. And his vision improved to 612, and the IOL was centered. These are the comparison of the pre and post-op results where the vision was improved drastically and the IOP and centration was fine in all the cases. In our case, the indication for going SFIL was trauma in 2 cases and spontaneous dislocation in 1 case, followed by capsular deficiency in 1 case. We found a complication of IOP rise, which was managed like medically, and IOL decentration was seen in 1 case, for which we had to go for resurgery. Iris hook plugs can act as a novel and a cost-effective approach which helps in exteriorization as well as stabilization of the aptic, formerly where assistant surgeon has to stabilize the aptic while the surgeon is manipulating the other half of the aptic. In a study by Ko et al. Found that IOL dislocation and raised IOP were more when we go for anterior approach, which was also be seen in a similar study by Sen et al. More in pediatric population. The lens tilt can be minimized by ensuring a 3-piece IOL has a haptic design that covers the full diameter of your ciliary sulcus. Zeng et al. Reported an IOL tilt of 2.3 degree when we go for Emanis technique, which is similar to the IOL implant tilt which we see after a normal cataract surgery. And haptic stabilization and exteriorization are crucial steps when it comes for SFIOL. Usage of high-risk hook plugs could be a cost-effective alternative rather than depending upon a costlier alternative such as XNIT. Superior visual recovery and better safety profile makes it the choice of secondary IOL in modern practice, though complications like aptic breakage, IOL dislocation have been reported. Thank you.
Thank you, Renuka. It's a very wonderful presentation. The only thing is that I would like to share my experience. Even for the iris hook plug, you have to have an iris hook. So how can it be cost effective? What we do instead, the IV cannula, even the small IV cannula or that you use with the Simcoe cannula, you just cut a small piece of that and make a square shaped and you just penetrate the 26 gauge needle with that. It works the same way. We are using that. So it is the least cost effective. So I should come up with the paper I have declared.
Yeah. Nice. Nice, Dr. Saroj.
So the small IV cannula, so you can cut it, make it a square shape, flatten it. That cannula you divide it, it will flatten, and then make it a square shaped piece, and you penetrate the 26 gauge cannula. It works the same way. Iris hooks is quite costly. It's not easy to get it. So thank you. Thank you very good.
Thank you very much.
We have the last. Dr. Shruti Bachi last.
So the next.
Shruti Kochar.
So the next speaker is Shruti Kochar.
A very good afternoon. Thank you, Scientific Committee, for the opportunity. The authors have no financial interest in this presentation. I'm presenting to you our new innovation. We call it Universal Integrated Electronic Eye Drop Sleeves, a novel compliance monitoring method for glaucoma patients. We all know that glaucoma has a huge impact on vision loss and blindness, and it is the second most common cause of blindness worldwide. And the topical medications are the gold standard, we all know. However, always non-compliance is a major issue. And literature suggests up to 50% non-compliance and 35% faulty administration in glaucoma patients. And it is a known fact that if you don't adhere to medication, it can lead to progression and vision loss. So the research question we had was, is there any role of alerts or reminders at drop taking times enabled by smartphone enabled technologies so that we can prevent this? So the aim was to innovate an integrated technology that can register a successful drop delivery and communicate the same information both to the patients and the care providers. And the secondary aim was to check the efficacy of this device using a validated questionnaire before and after the use of device. So with the help of my IIT colleague, I designed this with my co-patenter, a fully integrated electronic eye drop sleeves and 3D printed it. So the auto drop consists of 4 major systems. First is the power system, which has a rechargeable cell. Second is the microprocessor. This is the microprocessor. Third is the inertia control system responsible for the orientation of the eye drop, whether it is falling in the eye. And the final is the pressure detection system. So the final assembly looks like this. You can use any of this eye drops, so it's called universal, and you can stack it up very easily like this, and you're good to go. The auto drop device has a USB-C port, and with just a charging of 3 hours, it can last for up to 20 days. It comes with a drop guider, the blue one, and as soon as the drop gets instilled, it gets updated on the mobile app. So here is a quick demonstration of how the whole thing works. The app will send you a reminder. No matter what you're doing, you will get the reminder, and you can use this assembly with a drop guider and instill that into the eye. As soon as the drop gets instilled, your app has an alert that the drop has been instilled. So I'll also explain the app interface. It has 2 options. Number 1 is connect the eye drop, and another is schedule your eye drops. You can connect as many eye drops as you want, and you can set reminders to get notified. And these drops get connected to the app via Bluetooth device. So we can also, to validate and see how efficacious this is, we conducted a hospital-based cross-sectional study among primary open-angle glaucoma, age above 18 years old, and we used a semi-structured questionnaire to assess the reported problems in adherence and other problems, if any. So this is the questionnaire we use. It has many pointers like demographic data, number of eye drops they're using, bilateral or unilateral, what is the main problem of no adherence, and age group and other factors. So here's the demographic data. We took about 80 eyes, and in this study, initially without using the sleeve, we found that up to 50% non-compliance was there, up to 50%, including total and partial non-compliance. So the main reasons of non-compliance were, number 1, forgetfulness was the main reason. Sometimes your cost effectiveness, that the drops are getting over very quickly. Glaucoma medications are expensive. Unavailability of drops, going out station, and discomfort and laziness. These were the things we observed in our study. Then in a subgroup of the study, we gave them our sleeves, and after 30 days, we called them again and asked them to repeat the questionnaire. So we found a significant decrease in the total and partial non-compliance, and increase in the full compliance up to 85% from 50%, what was before. So we also did a subjective and objective compliance test, and we found that the 2 major causes were forgetfulness and compliance. And we found out that after giving the sleeves, the compliance improved, the forgetfulness decreased and compliance increased up to 87% in our study. Also, the duration of the time taken for the bottle to get over was very defined in this group. Sometimes it got over earlier in some patients because they used to put 2-3 drops, and in another group it lasted for 40 days because they did not put drops. Though the box and whisker plot graph shows that it got very standardized to almost near 27 to 30 days on using the sleeves. So what this device can potentially add new is it emphasizes the importance of compliance and minimizes the forgetfulness. It enhances the patient adherence for sure, and it can probably delay the progression if we stick to it. And we are trying not to give this cost to the patient. Additionally, we are trying to make the pharma company bear the cost to give it along with their drop, and only charge a nominal for the subscription of app, like some 99 rupees for 3 months or so, to make it little sustainable, and under the process of filing the patent for this product.
So to me, it appears like there are two parts to this presentation of how you actually put the eye drop and what is the compliance. Compliance has nothing to do with how you put the eye drop. Compliance is more about forgetfulness and all the things that you have mentioned, and you have elaborated very nicely. But I think the two things can be made out of this paper.
Also, we are trying to work on one laser technology, whether we make sure that it is falling in conjunctiva only. Many times it's a wasteful drop also if it goes out. So also refining the system with an infrared laser that detects conjunctiva, and it can, we are working on this part also for this.
So the app itself works as a reminder, so the compliance will improve.
Yes.
So in the older age group, when the patient usually they are a dementia, so even it will work in the patient who are having a dementia.
Connect it to multiple devices, like the sons or daughters who are not there also. It will send a reminder to them also to remind them if they are not putting drop. So it can be connected to multiple devices, and a CSV file can be exported to the person who is giving the drop, so that I also have a track of this. So it can send to multiple.
The patient is having diseases like Alzheimer and Parkinson's and all that, old age disease. How will you manage? I mean,
वही तो कह रहे हैं कि बच्चों के पास रहेगा ऐप, बच्चे रिमाइंड करें.
Suppose there are only two old persons. Like nowadays it is a nuclear family, and one is having glaucoma. Both are having the
It's actually compliance is an issue in glaucoma. You are right. Compliance is an issue in glaucoma. So if this device can help all class of people to put the drops in time, then definitely it is going to help. And it should be cost effective also. That is.
It is free of charge.
And it should be
combined.
usable all.
It is free of charge. Pharma will give it with their drops.
But why will this thing is going to cost thousands of rupees making it? There's a chip, there's a sensor, there's a battery, there's a charger.
So for our previous patent also, we collaborated with IIT students. They are very enthusiastic and they are not bothered of money, and we are also not bothered about money.
But the pharma companies will be bothered.
So costing is not more than 2 lakh rupees what we have paid, or from our side, because my hospital gives me a...
No, when you are making it on a large scale.
Large scale, yes. So we'll tie up with the pharma company, and they can combine with their eye drop to give it.
Very
and we'll
good
only
idea.
charge for subscription of the app, 99 for 3 months. Only rupees 99 for 3 months for the app.
Good idea. Thank you very much.
Thank you so much.
To the end of the session, I'd like to thank Dr. Ajit Podar, Dr. Saroj Gupta and Dr. Rajinder for being with us. I am Dr. Satyajit Sinha, and would like to congratulate everybody. All of you made some wonderful presentations. You learned so much, we learned so much, and eventually we wish all of you best of luck, and there's a lot of learning to be done. Thank you very much.
Thank you, sir. Thank you, everyone.